and has been in Bermuda for the last 32 years, working at King Edward VII Memorial Hospital. She married Brother Stephen Phillips in 2001 and was baptized into Christ in July 2007. One of our speakers. Join me, Sister Jan. And then there's Sister Rhea Outerbridge. Sister Rhea is a member of Brighton Hill Road Church of Christ and is currently the lead for their health ministry. In 2004, she married Brother Kirk Outerbridge, and they share two delightful sons, Miles and Mesa. Okay, worthy names, okay. She is the Perioperative Services Clinical Manager for King Edward Memorial Hospital. Join me, Sister Rhea. And it's all theirs.
So, good morning, ladies. I'm Jennifer Phillips, and I'm up first. And I just want to impress upon you that you'll be glad that I am not going to sing. Because the two ladies that went before me, the sisters, have beautiful voices. I can't carry a tune, although I love to sing, but you wouldn't thank me for it. Okay, so I am going to talk this morning on the importance of foot care in diabetes. And the reason for that is that I am the clinical manager of the hyperbaric and wound care department at the hospital. And on a Monday, we have what is called a diabetic foot clinic. So we see a lot of patients with wounds, and they are wounds that could have been avoided if, not all of them obviously, but if they'd paid particular attention to their feet. So that's why I want to stress that importance. And now, it's from the beginning. Yeah. Why is it not doing what we want it to do? But it's not. Sorry, slight technical difficulty. Double click it? Ah, okay. There you go. That's why I need Sister Rhea with me. Okay, yeah. So the importance of foot care in diabetes. Benjamin Franklin once said that an ounce of prevention is worth a pound of cure. And it's interesting to note these figures are probably about 5 years old now, but unfortunately it's really not getting any better. At the moment, 1 in 12 people have diabetes. 1 in 2 people with diabetes are unaware that they have it. And every 7 seconds, someone dies from diabetes or a diabetes-related illness. Okay. So in Bermuda, for many, many years, the GPs used to tell patients, oh no, you're not diabetic. You've got a touch of sugar. I'm sure the older members of our congregation here will actually remember that, because they did. I can think of like Dr. Kressel, that was his favourite. Oh no, you're not diabetic. You've just got a touch of sugar. Unfortunately, a touch of sugar means that you're diabetic. It's like telling someone, oh, well, you're a little bit pregnant. You're either pregnant or you're not. So, diabetes is a disease in which your body either can't produce insulin or can't properly use the insulin it produces. So insulin is a hormone that's produced in your pancreas, and its role is to regulate the amount of glucose or sugar that's in your blood. And the blood sugar has to be carefully regulated to ensure that the body functions properly. If you have too much blood sugar, it can cause damage to organs, blood vessels, and nerves. And your body also needs insulin in order to use the sugar to change it into energy for fuel. So we have type 1 diabetes and we also have type 2 diabetes. Type 1 was formerly called insulin-dependent diabetes, and that results from an autoimmune destruction of the insulin-producing beta cells in the pancreas. In other words, they're not producing any insulin. And that leads to an increased level of glucose in the blood and in the urine. And so type 2, which was formerly called non-insulin dependent diabetes, that accounts for approximately 90% of cases. And is characterized by high blood sugars in the context of you're producing insulin, but not enough. And you also have something called insulin resistance. And the primary cause of that is obesity in people who are genetically predisposed to the disease. I'm sure you know in Bermuda there are families that everyone is a diabetic. So that means that those people are genetically predisposed to having diabetes. And if they put on a lot of weight, for example, they can become diabetic. So in 2012, in the United States, there was 29.1 million Americans with diabetes, or 9.3% of the population. And 8.1 million were undiagnosed. And 25%, just over 25%, so that's a quarter of them, were seniors aged 65 or older. Now, in Bermuda, it's estimated that there are approximately 13,000 people with diabetes. The incidence of diabetes is higher in lower socioeconomic groups, older age groups, Black, Asian, Portuguese, and Filipino populations. And the incidence overall is 8% in Bermuda. It's difficult really to know exactly because reporting of diabetes is affected by if people are uninsured or just the way our health system is at the moment. It's quite fragmented. And also there are cultural concerns, like some people would never admit that they were diabetic, for example. But sometimes, you know, ignorance is not bliss. Interestingly, more was spent on healthcare for diabetes in North America and the Caribbean than in any other region. And we're talking about like that's in comparison with places like Canada, Switzerland, and the UK. It's estimated that there's probably about 20 to 25% of the population in Bermuda is diabetic. And they also believe that for every 2 known cases of diabetes, there is another one that's been undiagnosed as yet. So optimal blood sugar levels. A normal HbA1c, an HbA1c is a blood test that will tell you what your blood sugar level has been like for the past, say, 6 to 8 weeks. So they can see what it was running at. And for people without diabetes, the range is between 4 and 5.6%. Between 5.7 and 6.4%, that means you're at an increased risk of diabetes. Levels of 6.5 or higher indicate that you actually do indeed have diabetes. And the goal for people with diabetes is an HbA1c less than 7. So these, I'm going to show you some lovely pictures, okay? These are diabetic foot ulcers. They are caused by, well, they're caused by pressure. They're also caused by lack of sensation. So diabetic foot ulcers, they develop as a result of damage to the nerves, which is called neuropathy. You can have sensory neuropathy, where you have loss of protective sensation. So, you know how if you touch something that's hot, you automatically pull away? Well, when you're diabetic, you don't have that same level of sensation. So you can be prone to burns, you can be prone to pressure, your shoes rubbing, and you just don't feel it. And in actual fact, I might as well digress a little bit. I've had patients who came to us and had no idea that they had wounds on their feet, caused by one lady had a pair of spectacles in her shoe, and she didn't feel it, so it was causing her more and more and more damage, and she got an ulcer. Another gentleman, he didn't realize he had something on his foot until he walked across his bathroom floor, and there was blood on the floor, and his wife said, "Where's that blood coming from?" He's like, "Oh, I don't know." He had a nail about 4 inches in his foot, and he had not a clue. So that's why we have to check our feet when we're diabetic. Motor neuropathy, that causes muscle wasting and affects muscles required for normal foot movement. You can get collapse of your arches, and you can also get hammer toes. And autonomic neuropathy results in decreased sweating, you get dry skin, and it cracks. So these are the areas where pressure is prone in diabetic foot ulcers. So you can get them between your toes, you can get them on the tips of your toes, you can, anywhere you've got a sort of bone or a bony prominence, you can get a pressure injury. And we've seen them in all these areas. Okay, so you can also develop, if you get repeated trauma, and of course they're not feeling their feet, it's repeated, eventually it will do damage, and they can end up with something called a Charcot foot. And that just gives you the sequence of events for a Charcot foot. But if you look on the left-hand side there, you can see that. That's a lovely ulcer. That's not homegrown, by the way. I took that off the internet. But we have ones alive and well in Bermuda with equivalent ulcers. So early interventions or prevention is what we really want. So if you are diabetic, or if your relative is diabetic, this is what you need to do for their feet. They have to have careful and frequent inspection of the foot. And that is the most effective and least expensive method of preventing ulcers and possible lower extremity amputations. At least 50% of all amputations due to diabetes are preventable with early intervention. So that's half. Think about that. Prevention interventions for the patient with lower extremity neuropathy or reduced sensation in their feet, it must become a routine that the patient incorporates into their everyday life. Inspection. Their feet and toes should be inspected daily for blisters, cuts, swelling, redness, or any other discoloration. Because, just to say, when you're diabetic, especially if your blood sugar is out of control, if you've got high blood sugars, bugs love that. It's a breeding ground for infection. They think, yes, I'm going to get food, because they thrive on the sugary blood. And so what happens is, if you get a small cut, it can rapidly develop into something really quite nasty. So inspection, absolutely every day. If you're unable to see the bottom of your feet, right, use a mirror, or ask someone, ask a family member, can you see, is there anything between my toes, or is there anything on the bottom of my foot? You should look for dry areas and cracks in the skin and apply moisturizer every day after bathing. Inspect your feet daily, and also, I've written here, trim your nails and calluses when required. But as a diabetic, I would suggest that if you know anybody who's diabetic, or you are diabetic, that you go and see the podiatrist or the foot doctor every 3 months, so they can trim your nails and inspect your feet for calluses and, file them down. You should wash your feet daily, dry them carefully, including between your toes, and you should test the water with your hands or your elbows to ensure that it will not burn your feet, because as I stated before, if your sensation is impaired, you can get a bad burn and not even realize it. okay? Don't soak your feet. Soaking actually dries the skin by removing the natural oil and can cause maceration. You don't want that. You should apply moisturizer to your feet, but not in between your toes, because you don't want them to get more macerated and more moist. Cut your toenails after bathing when they are soft and easier to trim. Never cut your toenails too short. Leave about 1/4 of an inch of the nail left. They should be cut straight across and try not to shape them. Sharp edges should be filed down with an emery board to avoid cutting adjacent toes, because often as well, people with diabetes, even people who don't have diabetes, try and squeeze their feet into shoes that are cute, okay? And so sometimes your toes are over like this, and you get one nail digging into the toe of another. Ingrown toenails or other problematic nails should be cared for by a foot care provider, a podiatrist, as I said. And absolutely do not dig under your toenails with sharp objects. Don't use if you have corns and calluses, don't use the chemical corn or callus removers, because they can damage the skin. When your feet are dry, you can get a pumice stone and file away the callus. Corns and calluses are a response to pressure from poorly fitting shoes, and you should change your footwear to reduce these hot spots. Shoes. People with diabetes should wear shoes at all times, even when they're in the house. When you get up out of your bed, you should put on your slippers, because you don't want to risk standing on something and, sustaining a cut. So do not wear barefoot even in your own home. Wear slippers with a rubber sole, or wear socks and shoes outside at all times. Ideally, shoes should have thick, flexible rubber soles, closed toes and closed heels. They should be sufficiently wide for your feet. Always avoid, I'm just laughing because, I say this, but, we all wear cute shoes. I'm just getting around it, okay? Always avoid pointed toe shoes or boots. Running or walking shoes are the best ones to buy, because they're nice and wide. Don't depend on breaking in shoes. You know how sometimes you buy shoes and you think, oh yeah, they'll be fine once I've broken them in a wee bit. Don't do that. And you should also buy them later on in the day when your feet are at their largest. Inspect your shoes every day, inside and out, and not just for the roaches, because sometimes you do that. You want to say, oh, is there a spider in there, or is there a... Just make sure that there's nothing in there, because, as I say, some people with diabetes don't feel it, and they can walk around with things in their shoes for days. Do not wear sandals with thongs between your toes. And in winter, take special precautions to avoid foot damage. Talking about sandals, the same would go for toe rings. An aunt of my husband's many years ago, she loved to look cute, and she used to wear these little toe rings, and they looked lovely, but she got an infection in her toe, and the doctor said to her, stop wearing toe rings, because if you do, it's just going to get worse. But no, she wanted to look cute, so she carried on wearing the toe rings, and unfortunately ended up with a below knee amputation. So that is something to bear in mind. She did really well after she had her amputation. She did marvelously, but it's just, she'd rather not have had it, I'm sure. So there you go, suitable footwear. Back in China, Imperial China, back in the day, when they wanted women to have shoes feet about this size, they used to bind them to make them small. But now, what do we do now? We wear high heel shoes with pointed toes. Socks. You should wear clean socks every day and avoid nylon socks as much as possible. Socks need to fit well with no tight elastic at the top or at the seams. Now, we often suggest to patients in the clinic that they wear white socks. Now, that is because if they are vision impaired and they can't see very well, like my mate that had the nail in his foot, if say you bleed, you cut yourself and you're bleeding, it's going to be really obvious on a white sock. You would investigate it. Whereas if you were wearing a black sock, you might not notice it. Circulation. So we talked about the neuropathy and the nerve damage. You can also get ischemia, which is a reduced blood supply to your foot. And that can start with pain, callus, you can get numbness, deformity, ulcers, and then you can also lead to gangrene. And the photo on the right is what can happen once gangrene sets in. And that can happen extremely quickly. You know, not overnight, but not far off it. Within a week, it can go like that. So you have to absolutely look after your feet or look at your feet. Okay, so the way that we talk about the risk and what you should do about your diabetic foot, right? You're low risk if you've got no risk factors present, no loss of sensation, no signs of peripheral vascular disease, and no other risk factors. Whenever you go and see your GP as a diabetic, your GP should say, can you take off your socks and shoes and can I have a look at your feet? But I can say anecdotally, I don't know if any of them actually do that. So if you are diabetic and you're going to the doctor for your checkups, could you say, oh, could you have a wee look at my feet, please? Because, you know, I am diabetic and there might be something there. So if you've got one risk factor present, if you've got loss of sensation or signs of peripheral vascular disease, which means you've got reduced sensation you've got reduced sensation and reduced circulation, then annual assessment by a podiatrist. And, you know, you go on it from there, from what he finds. If he finds that you need to see him regularly, you need to go every 3 months instead of annually. You work that out. So that's moderate risk. If you have, high risk, right? If you've had a previous ulceration or amputation of more than one risk factor, then loss of sensation, signs of peripheral vascular disease, or a callus, or you've got a deformity, you need annual assessment by a specialist podiatrist, agreed and tailored management treatment plan, and they should provide you with written and verbal education with an emergency contact, okay? So that would probably either be your GP or the hospital for an emergency contact, or the podiatrist themselves. And then we move to active. If you actively have an ulceration or spreading infection, critical ischemia is when the circulation is probably occluded to your toes or your foot, or if you've got gangrene, like the picture I showed you previously, or unexplained hot, red, swollen foot with or without the presence of pain, you need to go to emergency and you need to be seen. You might need IV antibiotics. You might need a vascular surgeon to help with your circulation. You just can't play with these kind of things. If you've got anything at all, it needs to be, you need to get it seen to. And if they say, oh yes, that's fine, great, but it's better to err on the side of caution. So why is this all so important? So the potential for loss of limb or amputation. People with diabetes are far more likely to have a foot or leg amputated than those without. The rate of amputation of lower leg in diabetes is 28 times greater than other people. And additional amputation of the remaining limb within 2 to 3 years is between 50 and 84%. Now that is scary. And then 3 years after a lower extremity amputation, the mortality rate is 20 to 30%. So, you know, you're shortening your life. So, Bermuda's amputation statistics. A study of 30 affluent countries affected by high rates of diabetes. I think Bermuda was like maybe number 15 on the list. It wasn't as high as it is within the Caribbean. Bermuda was found to have the highest amputation rate among women, 46 per 100,000 people, and second highest for men at 43. And that is compared to the average rate of 15 per 100,000. So that is more than 3 times, ladies, more than 3 times the average rate of these other countries. Okay, any questions? No, have I stunned you all into silence? Okay then, I'll
Okay, all right,
Sister Door? Uh-huh.